Hello, welcome to this short talk. It'll be about half an hour just to get you into the mood for carrying out emergency endodontic pain problems. I've called it Pearls of Wisdom because I've used this title before when I've given some tips on how to carry out endodontics more effectively. I hope you're all well and you've got over this terrible time, and we're hopefully nearly getting back to practice. But I suspect there's going to be quite a lot of patients who have got endodontic problems and have had them for quite some weeks and will want to get over them as quickly as possible. So what I'm going to talk about today is a few tips on how to achieve predictable endodontics given the problems that we've got. We obviously want to have predictable endodontics because we don't want them to be any worse off than they were before, and obviously we want to get them to be better. So let's make a start, should we? Who was the enemy? Who are we working against? Well, at one time it was bacteria, but you know what? We're in a new age now. We're in post-COVID times. So who is the new enemy now? And that's COVID-19. So once we've dealt with that, and I'm not going to go into PPE or the requirements thereof, I'm assuming you're going to have those, but I will talk a little bit about rubber dam later, which obviously forms part of the protection for us more than for the patient. So what are we going to talk about in this first part? Well, I'm going to talk about quick x-rays. Most of you will obviously have the facility for this. I'm going to talk about assured anesthesia. This, in my opinion, is one of the least well-taught parts of dentistry. Sorry, I forgot to start my stopwatch because I want to make sure I don't overrun. Sorry, I'm going to talk about assured anesthesia because we obviously want to make it really numb when we get into it. I'm going to talk a little bit about rubber dam, which actually has become a lot more important since COVID, and control of acute pain. So that's dealing with patients who are in acute pain. I'm not going to necessarily talk about full treatment, but at least to get them out of pain. So let's move on. In part two, I'm sorry, what I should have said was in part two, which is going to be a second recording, I'm going to talk about accessing fine canals, length control of root fillings, retreatments, which I think will be quite a problem in the near future, and treatments of severely damaged teeth, which is also going to be very important because a lot of these teeth have gone for 9, 10, 11, 12 weeks without being treated, and some of them will have broken down, but even though the patients want to try and save them. I should say I've had quite a lot of phone calls from people who have been desperate not to have extractions, which seems to be the only thing that the urgent dental care centres have been able to offer so far. So those people who have been putting up with it, maybe with analgesics, are going to have some severely damaged teeth as well. So we'll talk about that in part two. So what are we going to talk about in quick x-rays? Well, obviously digital radiography is the treatment of choice. I hope most people have moved over to this and we're not still using wet films. I think it's unlikely, but most people I think have gone over to digital radiography. My personal choice, and I know there's lots around, has been SHIC for quite a long time. I find it gives me good images, it's nice and quick, it's easy to use, it's fairly mobile now because I can use it on a laptop if I want to. And there's different sizes of sensors available. There was a Wi-Fi, a Bluetooth one, a remote one at one stage, but I believe that's now been taken off the market. I know there are other makes, I've tried other makes, but I keep coming back to SHIC. The only downside I think with SHIC nowadays at the moment is that it's not available as a web-based or cloud-based product. So even though I can get dental records of all my patients from the cloud, and I particularly use Dentally, I can't get the x-rays, and I'm hoping that soon CUEW will move over to that to make life a little bit easier when I'm not around and patients phone at the weekends or evenings. So as I say, I use CUEW. We get nice, quick, clean images, as you can see here. And if we can't quite read it properly, we can manipulate it, we can enhance it, we can colorize it, we can reverse it black to white. The one thing we can't do from a legal point of view is actually modify it. We can't use any of the programs that will modify it. I think that's been considered to be quite immoral and probably now illegal anyway. So we get good images, we get it well stored, and it's nice and quick. Ironically, when I first started using digital x-rays, way back in the 1990s, we used to get even faster x-rays than results than we're getting now. I'm told now it's because they are just such large files that it now takes up to 4 seconds to get an instant image. We used to complain when it took 4 minutes to go out of the room, process it and bring it back. Now we're hitting the table if it takes 5 seconds. Sorry, did I say seconds? I meant 4 minutes to go out of the surgery, have it developed and brought back while we were twiddling our thumbs. Now if it takes 5 seconds, we're hitting the table saying, come on, hurry up. But that's the way life goes. But anyway, it's nice and quick. We get good x-rays, and the important thing, as I'll come to in a minute, is that if it's no good, if you've missed the apex, heaven forfend, or you don't like it, or maybe the file's a bit too short and you want to extend it, then you can do that straight away, and it's quite quick. They're easy to use while the rubber dam is in place. I use the CUEW size 1 sensor. I found the others too big and too bulky, and they just get in the way of everything. This is a rin holder that I've modified particularly for lowers. So as you can see, there's a groove there which allows me to pass that around the files when they're in place. I should add that actually I don't use an apex locator. I've never come to terms with them. And perhaps an argument for another day, I actually can't see the logic behind them at the moment. And in my opinion, they're not as accurate as digital radiography. In fact, the manufacturers don't even claim the high sensitivity rate. They talk about 80–90%. In my opinion, x-rays are 95, 96, 97% accurate. So in fact, I think they're a little bit better. It also means that it's easy to do. This is my old surgery before I moved away from Malthouse. So the patient was in the chair. We didn't even need to move the microscope. We just simply took the x-ray and it came up on the screen immediately. This is the size 1 sensor. In size, it's actually slightly smaller than the old E-speed film. So you've got to be a little bit more accurate taking the picture. If you use a size 2 sensor, I find it's actually just too big and it's not that easy to take a picture. So I use a size 1, and with aiming devices, it's not a problem. After all, we're only taking one tooth. We're not taking bite wings, and we're taking them vertically. I don't like horizontal ones because they're not as accurate. And I find these just as easy to take. Obviously, we put them in a sheath, even more important nowadays, of course. And we may actually now have to use even longer sheaths to cover the wire for quite a long distance as well. These just look like large condoms, which probably they are in actual fact. I wouldn't even be surprised if they're made by the same people in the same factory. I'm not suggesting any interchangeability, by the way. So I take it like that. Actually, I don't use a holder for uppers, or I tend not to use a holder for uppers. Ignore the rubber dam for the moment. We'll come on to that later because I don't think rubber dams should be like this now post-COVID. But I just get the patient for an upper x-ray like this, upper radiograph like this. I get the patient to use their contralateral index finger just to hold it in place, and then I carefully aim the head. Mostly nowadays, of course, they're rectangular, not round, although to be honest, I actually prefer the round ones. For a lower, there's different holders. There's a metal one. I showed you before the plastic one, the RIN one. The advantage of this one is it's got the little bar on the end, so you can actually get a bit more of an accurate layout, aim for it. As you can see, the patient just holds it in position. They don't even need to sit up. We can take it with them still lying down. Now, a lot of you, I suspect, will be using phosphor plates. I have to admit, in one of the practices I worked in recently, I used phosphor plates, and to be honest with you, I didn't get on with them. First of all, I think they're more difficult to position and for the patient to hold, or even to use the holders. But secondly, I don't think they've got the advantage of rapid x-rays, because it still takes 3 or 4 minutes for the nurse to go out of the surgery, process them, put them onto the machine, and then show them up on my screen, by which time I've had the 4 minutes I could have used a wet one in the surgery. In addition, I think we're going to have a lot of problems in the future now with phosphor plates, because the nurse is going to have to, we're either going to have 2 nurses, one of whom is going to take the phosphor plate out of the surgery, process it, bring it back, pass it under the door, or whatever the regulations and protocols are likely to be. So from my point of view, a CCD or CMOS sensor is going to be the better option. I suppose a phosphor plate would be okay if you've got the processor there actually in the surgery with you. That would be okay as far as I can see, but otherwise I think it's just going to be a general hassle. So I think what's going to happen is, if we're obviously going to need to take an x-ray at the beginning of the appointment, just to see what's going on, even before we do anything else. And once we've made the diagnosis, then we're going to have to go ahead and do the treatment. Now, I'm assuming we're doing patients with pain, so we're going to have, obviously, to be assured that we can get some decent anesthesia so that we can carry out the treatment. So there's different types of anesthetic techniques available. Some listed here: inferior dental, infiltration, intraligamental, intraosseous. The new electronic ones, I used to use the wand, intrapulpal, and some others. I should say that I actually haven't done an inferior dental injection for probably between 25 and 30 years. That may surprise some of you, but I'll come on to that later. And sorry, I might as well cover it now actually. Why not inferior dental? Well, in patients with hot teeth, hot lower molars, severe pain coming from lower teeth, in particular irreversible pulpitises, practically speaking, inferior dentals don't work in maybe 75% of cases. So even these people here, I just refer to a couple, could not get anywhere near 100% success. The literature, as far as I can see, is somewhere around 25 to 30% success with intraosseous. It doesn't get that much better even with lingual infiltrations, buccal infiltrations, whatever you want to add to it. So you may as well not use it in the first place and find a way around it. So, I mean, they only got up to 60%, as you can see on this one. They didn't do much better. And so I gave up using inferior dental quite a long time ago. What about intraosseous? Well, if any of you have tried it, you probably realize that you actually lose more weight from perspiration yourself from trying it, because it's so horrendous, than the ability you get to achieve suitable anesthesia. I say that a little bit cynically. The first one I ever used was actually attached to the handpiece, and I thought I was going to go completely anorexic because it was so horrific to use. There's a Stabident one. I used that for a while, but to be honest with you, once you've drilled your hole, you can't find it again to put the needle in. So you finish up poking several holes and the patient doesn't thank you for it. That's the theory behind it. The practice is quite another matter. But that's what you're supposed to do. Drill a hole, find it and put the needle in. Impossible. To find it like this, no go. The X-tip came along and said, right, well, let's drill a hole and let's put some sort of guide in. That's fine. It doesn't work anywhere near as well either. I didn't like it. Again, I lost weight just from perspiration, from the fear of it. So I gave that one up as well. This then became my favourite, the wand. If any of you are using it, I'm sure you would never let anybody take it away from you. I unfortunately made the mistake of selling the practice and then leaving, so they did take it away from me. And I was too mean to buy another one afterwards. In fact, they'd gone up ridiculously expensive, but they are really worthwhile. But as I'm only doing a bit of part-time now, I don't think it's really worth it because I found other ways of dealing with it. So what kind of anaesthesia do I use to deal with these hot teeth or these irreversible pulpitises or periapical periodontitis, excuse me. I should say I'm very new to this technology, so I'm not quite sure how to stop it and edit it and start it again. So if I make a few mistakes, I apologise. I'm hoping I'll get better as time goes on. Okay, so what about, let's start with uppers. Well, upper anteriors are not that difficult to make. Numb of buccal infiltration with lignocaine should do it in most cases. If it doesn't, then you could always either use an incisal supplementary or an articaine supplementary. I don't like using articaine as the primary injection. I'm very happy with lignocaine. It seems to work in my hands. If you're happy with articaine, feel free to use it. But as I say, upper anteriors, buccal infiltration seems to be okay. Premolars, I tend to like to use a buccal infiltration, again with lignocaine, and I might also add, especially in severe pain, a palatal infiltration somewhere between the 4 and the 5, about halfway down from the gingival margin to the palate. Some people, particularly the wand people, say that you can just use that as the only injection. Personally, I like to. I'm a bit of a belt and braces man, so a buccal infiltration and a palatal seems to cover it. Upper molars, I now always use a lignocaine buccal infiltration and a palatal just slightly distal to the tooth, again about halfway between the gingival margin and the palate. Don't use too little when you're doing a palatal. You need to use quite a bit of material until it at least blanches to show that it's got the blood vessels as well, and then you know that it's actually working. I don't like just sticking to a buccal infiltration because very often it's the palatal root of an upper molar that's causing the problem, and therefore it's much better if we can make the palatal completely numb. Again, in a very hot tooth, in a premolar or molar, I'll also give an infiltration of articaine after I've used a lignocaine. As I say, I'm belt and braces, and it doesn't do anybody any harm, and it can only do a bit of good. Lowers are slightly different. Anteriors, I tend just to use a buccal infiltration. Sometimes I might use it either side of the tooth just to make sure, especially centrals, because there's some overlap from the other side. So I might just give a couple of infiltrations, one over the apex of the tooth and a couple either side. Lower premolars, I tend to use mental infiltration or to try and find the mental foramen, or just a buccal infiltration with plenty of solution and just massage it around just to make sure that it spreads. It tends not to be a problem getting them numb. In my opinion, there are greater problems involved in dealing with lower premolars than getting them numb. I think, and I think quite a lot of endodontists would agree, that actually the most difficult teeth to treat are lower premolars when they've got a very acute infection and pain. Lower molars, well, this of course is where the inferior dental comes in, or in my case doesn't come in. What I tend to do nowadays, I'm sorry if this picture, I've just realized this picture might overlie what it says over there, but the first thing I do is give a buccal intraligamental injection midway between mesial and distal in the furcation area. I'll show you the instruments I use in a minute, and I tend to use lignocaine to start with. So I give most of the cartridge in the buccal intraligamentary position. There is some evidence in literature to show that this actually becomes an intraosseous because the fluid flows through the buccal plate and into the cancellous bone, so it acts as an intraosseous injection. I use lignocaine with that, and then I follow up with a buccal infiltration of articaine over the apices of the tooth in question. Some people do it the other way around. This is just the way that I've developed, and I find that it tends to work. And I have to say, not in 100%, but certainly more than inferior dental blocks percentage success rate. I also give a lingual infiltration subperiosteally about in the area of the furcation, on the lingual aspect, just to, again, belt and braces. It was a technique that I learned in Boston when I was in the States. And I try and get the needle under the periosteum to try and get a little bit of anesthesia on the lingual aspect. If for nothing else, it protects the gingivae against becoming painful with a rubber dam clamp. So those are my main methods of making it. This is now my favorite, my injection system for lower molars. It's the one I use unfortunately is only a 1.8 mil cartridge syringe, but nonetheless it won't take 2.2s because it hasn't got an adapter for it. But that's the one I use for the buccal intraligamentary, which, as I say, becomes intraosseous, and I use lignocaine in that. Incidentally, when I do the buccal infiltration with the articaine, I tend just to use a regular dental syringe. Now, rubber dam, if any of you have been following all the different SOPs and protocols that are coming out, is now becoming essential not only for endodontics, but for most routine dental treatment. Now, I'm not going to go into too much detail about rubber dam because most of you, I'm sure, know how to use it. I'm just going to very briefly point out a few little pointers while we go along. This one is the one I like, the hygienic one, although you'll see that this is 6x6. I personally like to use 5x5, although I may have to review that now, as I'll come on to in a minute. I've used 5x5 with a 5x5 frame for a very long time, but as I say, it's possible that we may have to review it in the coming months. I tend to use single tooth isolation, so this is for an upper premolar. So I put the dam onto the frame first. I put the dam on the back of the frame. I understand some people put it on the front. Personally, I can't understand that one, but anyway. Then I punch the hole, put the clamp on, put the dam over the clamp, I should say, over its wing. So I have to use a winged clamp, and then place it on into position with the rubber dam forceps. It takes a few seconds, and then flick the dam over the wings with a probe. Sometimes I use Oraseal around the margins if it's not sealing too well. Broken down teeth, obviously we use slightly different techniques. I'm not going to go into that. That could be a lecture on its own. So the point I want to make about rubber dam, and that's why I showed this other x-ray, this other picture before and said it's not quite right, as is the blue stuff, you know, some of these other modern rubber dam methods are now not acceptable because everybody is saying that the new protocols mean that we should cover the nose. And that's why I'm thinking I might have to go over to 6x6 rubber dam so that the dam is higher up and actually covers the nose. This is, by the way, to protect the dentist, not to protect the patient. The problem is, and I've searched and searched and searched, I cannot find a photograph of anybody with the rubber dam over the nose because we were all so careful, hence the development of these others, to keep the rubber dam below the nose, ironically. So the other alternative actually, so that's no good, that's no good. That's getting close to it, but the rubber dam needs to be lifted up, so the dam frame needs to be a bit longer. Obviously the patient's going to be wearing some goggles or some safety glasses. However, this seems a little bit over the top, but it may well be that in order to protect the nose, we actually have to get the patient to wear a mask at the same time as the rubber dam. They're not going to like it, but then the alternative is an extraction, I'm afraid. So this is quite important. Now, what about these patients with acute pain? Some of these patients are going to have had pain for quite a few weeks. They're unfortunately going to having had to take antibiotics, which is not ideal, but what can we do? So we're talking about patients with symptomatic irreversible pulpitis or acute periapical abscesses. So the first thing obviously is to take an x-ray to make sure we know what the anatomy is like and we've got the right tooth, that we've made the right diagnosis. Then we've got to make it numb, then we've got to put the rubber dam on, and then we've got to do the treatment. So this is what I like to do, although actually we can't get hold of Cresitin anymore. It was a technique that I was taught by Schilder in the States. Cresitin is metacresyl acetate, which I'm not sure that you can get in the UK anymore, but it doesn't matter because you don't actually need to use that. But to be honest with you, I still call it a Cresitin pulpotomy. I'm still doing the pulpotomy, but I don't use the Cresitin. Now, Sod's law is that most of these teeth that you're going to deal with are lower molars with full metal ceramic crowns, and you've got to get through them quickly. You don't want an AGP lasting too long nowadays. We didn't want it before, but nowadays it's even more essential. So what I like to use is to go through the porcelain or natural tooth and amalgam. I tend to use these diamond burrs at the bottom, the Martin endodontic access burrs, or now they're called Endo access burrs. I like the shape of them. Personally, I can't see the logic behind blunt-ended access burrs. It just doesn't make any sense to me, so I like these coarse diamonds to make my access. Now, I'm going to talk about access in part 2 because that's also quite important. But what we need to do now is just get in quickly. The metal part of the bridge, the metal part of the crown, excuse me, or in fact a bridge if it is a bridge, I like to use these jet carbide burrs. Unfortunately, they bounce off porcelain. So if you can get in with the diamond first, go through the gold or the metal with the jet burr, and then go back to the diamond burr to produce the access cavity before you can get into the, so that you can get into the pulp chamber. Once you're in the pulp chamber, it's either going to be bleeding like mad or it's going to smell like hell. So the first thing to do is just to clean out the pulp chamber you can use a Gates Glidden, you can use an excavator. Sometimes they're just empty anyway. You might want to use an ultrasonic, but we're trying to minimize AGPs. So you need to get into the access cavity, you need to wash it out with sodium hypochlorite, you need to dry it, and then apply some quercetin, some metocresal acetate. As I mentioned, you can use cresifine, you can use eugenol. Most of you, I'm sure everybody's got some sort of eugenol in the surgery. That's the one I used to use, the metocresal acetate. Cotton wool, pledge it on tweezers, dip it into the liquid, whichever one you're using, dry it out a little bit on a cotton wool roll and place it into the cavity. Once you've placed it into the cavity, you can use, I personally like Cavit, some people like Glass Anima, some people like IRM, some people like all sorts of other things. My favorite is the red Cavit. It's easy to apply, it sets quickly, and it actually has one slight advantage in that it expands a little bit on setting, so it actually helps seal the cavity. These pulpotomies I've known last about 6 months, so you don't have to rush the patient back. I only found that out because one of the ones I did, the patient then went away and didn't turn up for about 6 months, and I know it worked. We try and get them back a lot quicker than that if necessary. I should point out that ideally the best time to do the root treatment is at the same time, but I think we're not going to have a lot of time to do that in the near future, so this is a very good way of getting around it. So I hope that's some way gone towards helping you with these acute problems. It just means that you'll be able to get the patients out of pain. I've noticed that this doesn't work in 100% of cases. It certainly works in 90-odd% of cases, and patients are very thankful for it. I should say also, just as a quick final thing, this even works on teeth that have been previously root filled. I think what happens is that any pain is caused by either fluid or gas that's produced, and simply opening the canals and opening the tooth eases that pressure. I should say, I forgot to mention it, do not put instruments into any of the canals. Just stick to the floor of the pulp chamber. If you put instruments into a canal and there's any vital tissue or semi-vital tissue, it's going to actually damage it more and make it harder. So I hope that helps. I'm going to record, now that I know a little bit more about it, part 2 at some stage, but I hope you've enjoyed this and that it helps, and we'll see you around at some stage. Thanks very much. And then in part 2 we'll discuss dry and wet canals, retreatments, quick x-rays and treatments of severely damaged teeth, but I might bring quick x-rays into a different order as well. So from that, as far as I can see, that